Hello, my name is Samantha Rockrohr, and I'll be going over my capstone, Better Nursing Care for Pulmonary Embolism and Right Heart Strain for MSU's capstone. Here is a slide going over the objectives that we'll be diving into for nursing care and PE management. The focus is on standardizing care through nurse-led protocols to reduce variability, which is crucial for consistent patient outcomes. Enhancing outcomes involves improving patient safety, minimizing ICU admissions, and promoting faster recovery via early interventions. Empowering nurses through education and digital tools strengthens clinical decision making, ensuring nurses are confident and equipped to manage complex PE cases effectively. Pulmonary embolism has emerged as a growing concern in healthcare, particularly due to its increasing mortality rates. Between 2018 and 2020, the number of PE-related deaths in the United States surged by over 11,000, reflecting not only greater disease prevalence, but also systemic care gaps. The physiological basis for this rise in fatality often lies in resulting strain on the right side of the heart. When a pulmonary artery is blocked by a clot, the right ventricle must pump harder to move blood through the lungs, leading to dilation, dysfunction, and potentially cardiac arrest. The phenomenon of right heart strain is especially dangerous because it can quickly destabilize a patient. Understanding the interplay between PE and right ventricular or RV failure is crucial for clinicians. This context sets the foundation for why a focused, protocol-driven, nurse-led intervention plan is not just timely, but also potentially life-saving. This capstone proposal was motivated by a critical clinical observation. Patients with acute pulmonary embolism, complicated by right heart strain, often experience inconsistent care due to variations in institutional protocols and provider experiences. These inconsistencies pose a significant risk to patient safety and outcomes. By examining how nurse-led interventions can standardize care delivery and mitigate these disparities, the project aims to bridge the gap between established best practices and frontline application. A protocol-based approach will ensure that nursing responses are not only timely, but also align with the most current evidence and patient needs. Ultimately, the capstone seeks to empower nurses to deliver individualized, evidence-informed care and adapts to real-time clinical changes while enhancing patient outcomes and nursing satisfaction. Understanding the clinical significance of right ventricular dysfunction is vital for nursing care. Right heart strain increases the risk of cardiogenic shock and mortality, demanding vigilant monitoring. Nurses utilize risk stratification tools like the Wells score and the American Heart Association guidelines to assess severity and guide care planning. A comprehensive assessment includes patient history, laboratory data, and imaging to detect venous thromboembolism and hemodynamic compromise, enabling timely and targeted interventions. The PICO framework, population intervention, comparison, and outcome, serves as the backbone for this capstone's projects. Clinical focus, the population includes adult inpatients diagnosed with acute PE and exhibiting signs of right heart strain. The intervention involves the application of a nurse-led standardized protocol aimed at risk stratification and guided clinical decision-making. This is contrasted with existing practice where care is less structured and more variable depending on individual clinicians and units. The outcome measure include clinically meaningful metrics, faster time to intervention, decreased ICU admissions, shorter hospital stays, and increased nurse confidence. Altogether, this framework defines a targeted, evidence-informed approach to optimize care delivery and patient safety. The literature for this capstone strongly supports the pivotal role of nurses in managing patients with acute pulmonary embolism. Excuse me. With acute pulmonary embolism, especially those experiencing right heart strain. Nurses are responsible for a broad spectrum of interventions, from bedside assessments and interpreting diagnostic tests to implementing therapies and alerting care team to decompensation. Despite the presence of clinical tools like the Well score, Geneva score, and PESI, few studies focus on standardized nurse-led protocols that could streamline risk assessment and intervention timing. This gap in literature points to an opportunity for structured nursing pathways to fill a critical need. Additionally, the review underscores that timely identification of RV strain via the D-dimer troponin, BNP levels, and RV-LV imaging ratios correlates with improved clinical outcomes. The synthesis of this evidence forms the foundation for the capstone's targeted intervention strategy. So this case study is basically something that I have experienced myself with a few patient details changed. This case study also illustrates the risks of inappropriate antihypertensive use in PE patients with compensatory hypertension. Mr. James Doe here had an elevated blood pressure due to a physiological response to right heart strain, but administration of labetalol without proper assessment led to acute decompensation. This underscores the importance of understanding the pathophysiology behind vital sign changes and the need for careful evaluation before medication administration to avoid worsening cardiac function. Nurses are at the forefront of PE assessment and intervention. By incorporating standardized tools such as the Well score into clinical routines, nurses can rapidly identify high probability PE cases and escalate care appropriately. These tools provide a objective basis for determining diagnostic and treatment pathways. Assessment doesn't stop there. Lab markers like troponin, BNP, and D-dimer, along with imaging data such as the RV-LV ratio on CT scans, helps confirm RV strain. Nurses must be trained to interpret these data in context to patient presentation. Equally important is the nuanced evaluation of clinical signs and history. For example, understanding subtle indicators of decompensation or compensatory mechanisms allows nurses to act preemptively. These efforts help stratify patient risk and inform decisions about hospital placement, oxygen support, and advanced interventions. Integrating clinical decision support tools into the EHR is a major innovation in PE care. Tools like the PESI, Pulmonary Embolism Severity Index calculator, can automatically assess risk based on patient data, prompting appropriate nursing actions and escalation protocols. Imaging continues to play a pivotal role, particularly computed tomography, pulmonary angiography, CTPA, and the echo. A right ventricular to left ventricular ratio greater than 1 is strongly associated with poor outcomes and helps categorize patient acuity. Beyond diagnostics, these digital tools support nurses in managing workflow efficiency and accuracy, ensuring clinical assessments align with emerging patient needs. When seamlessly integrated, they enhance decision-making, reduce documentation burden, and allow for earlier interventions for at-risk patients. While growing evidence underscores the importance of nursing roles in acute PE care, several research gaps remain. Notably, there is a lack of comprehensive studies that evaluate the effectiveness of standardized nurse-led protocols, especially those targeting right heart strain. Equally underexplored is the integration of decision support tools within nursing workflows. Although technologies like PESI calculators show promise, few platforms are designed with a nursing user in mind, limiting their practical utility and adoption. Lastly, the literature reveals challenges surrounding education and protocol adherence. Inadequate training, documentation burden, and inconsistent team engagement create barriers to effective implementation. Addressing these gaps through further research can lead to more robust, scalable nursing interventions that improve care and staff confidence. The Capstone's proposed protocol aims to standardize nursing interventions in PE patients exhibiting right heart strain by leveraging technology and targeted training. The central pillar is the integration of risk stratification tools like PESI and well scores directly into the EHR. These digital prompts assist nurses in conducting thorough assessments, initiating care pathways. Education plays a critical role. Intermediate care and ICU staff will receive focused instruction on hemodynamics, lab markers, medication indications, and recognizing deterioration. Quick reference guides and workshops will support protocol adherence. Development and rollout will be led by interdisciplinary team, including nursing staff, providers, QI, and EHR engineers. To ensure practicality, user-friendliness, and clinical alignment, the strategy prioritizes timely interventions, standardized decision-making, and team coordination to optimize outcomes in this vulnerable population. This policy slide stresses the importance of safe antihypertensive administration in acute PE patients. Healthcare providers must thoroughly evaluate contraindications before giving antihypertensives, especially in the presence of right ventricular strain and concurrent anticoagulant therapy. Recommendations include reviewing current medications, removing PRN antihypertensives from the MAR, and consulting providers and pharmacists for complex cases, and documenting treatment rationales to ensure patient safety and prevent adverse events. The PESI risk calculator integrated into EHR exemplifies how technology supports individualized patient care. It automatically appears in PE order sets and uses inputs like age, vital signs, oxygen saturation, and comorbidities to classify risk from 1 to 5. Features include flagging contraindicated medications and alerting providers to beta blocker risks to RV dysfunction. Links to guidelines and consult prompts facilitated information decision making, aiming to optimize antihypertensive use and improve safety in PE management. To ensure success, the capstone proposal outlines a detailed implementation strategy and starts with retrospective EHR analysis. This data will illustrate the increasing burden of PE, providing a clinical baseline and support the case for adopting a standardized protocol. A 3-month pilot program will be launched in one ICU and one intermediate care PCU that handles a high volume of PE cases. These units will be equipped with education models, quick reference tools, and real-time support. Nurse leaders and unit champions will guide their teams and collect feedback. Oversight is critical. The project depends on collaborative input from clinical leaders, hospital administration, QI, and education departments. Their expertise ensures that the protocol is evidence aligned, user friendly, and adaptable to evolving patient needs. To measure the effectiveness of proposed nursing protocol, the project incorporates robust pre and post implementation data analysis. By evaluating 100 to 150 patient records prior to rollout and following up with pilot units over 6 months, meaningful trends can be established. Key evaluation metrics include decreased in hospital mortality, fewer ICU admissions, shorter hospital stays, and reduced 30-day readmissions. Additional tools like EHR audit reports, control charts, and the Likert scale survey will help track usage, compliance, and perceived impact. The project also gauges how quickly nurses initiate appropriate treatments following risk stratification. Qualitative feedback is equally important. Interviews and anonymous staff surveys will assess how the tools affect workflow, decision-making confidence, and team communication. This holistic approach ensures that the protocol is not only clinically effective, but also practical and sustainable in real-world settings. Disseminating the outcomes and insights from the Capstone project is key to scaling its benefits and influencing broader nursing practice. Internally, results will be shared through executive summaries, presentations, and clinical meetings, facilitating transparency and team reflection. To reach a wider audience, abstracts will be submitted to nursing and healthcare quality conferences, while findings will be prepared for publication in peer-reviewed journals. These efforts aim to promote nurse-led intervention in PE management and encourage protocol adoption beyond this institution. Additionally, incorporating the protocol into hospital education systems supports ongoing staff development and ensures sustainability. Nurses will be able to earn continuing education credits, or CE, reinforcing professional growth while enhancing care quality. Dissemination will solidify the role of nursing in leading care innovations for high-risk PE patients. In conclusion, this capstone project illustrates the transformative potential of nursing-led protocols in managing high-risk PE patients with right heart strain. By unifying evidence-based tools, standardized assessments, and multidisciplinary collaboration, the protocol promotes earlier interventions, improved outcomes, and enhancing nursing autonomy. Beyond this institution, the model offers a scalable framework application to other time-sensitive, high-risk conditions. It highlights the capacity of nurses to lead complex care initiatives supported by data, education, and innovation. Looking forward, ongoing evaluation and refinement will be key. Future research will target broader implementation, identification of persistent barriers, and deeper exploration of technology-driven support for nurses. This capstone stands not only as a clinical improvement project, but also a model for nurse-driven advancement in health system performance. Thank you.